And at that time, people used to always think that pediatric endocrinology is one branch, which is basically very, very rare, dealing with rare, complicated disorder, which require cumbersome evaluation and expensive treatment. This was a common thing. Everybody used to say, what will pediatric endocrinology do? Nothing much to be done at this there. But when we started seeing patients, we were shocked by the way they were being managed. And this is one case with Dr. Rashmi and both of us managed. It was a very short child, diagnosed in 10 years with severe anemia, presented for the first time. And then at that point of time, there was a short stature and was given a blood transfusion, diagnosed as a case of celiac disease, but unfortunately had developed HIV because of the blood transfusion which happened in that scenario. So this was an unfortunate scenario, a case which should have been diagnosed at the right time and should have been managed in that perspective or missed in that scenario. So we thought, what are the problem? Is it a problem of awareness, accessibility, or affordability? Now everybody says it is always a problem of cost. So people say cost is a major problem. But what is the truth is actually the elephant of the house is awareness. If you don't know when should you go, where should you go, how you should be managed, it is difficult. Once you go, direction is there, people will help you. People will help the patient will help themselves, but most important is awareness. So from there, we started our program, and 2012, we had the first PPEC, and a lot of people here, including all the seniors, Dr. Subrato, Dr. Rishi, everybody was part of that program. And since then, we have conducted huge number of programs across the region in the country. But unfortunately, how many physical programs one can do, that is a limit to that. So we started the advanced programs as well. So we moved forward from there to internet media, because now internet is available. So we started on YouTube around 7 years ago. And from there, we moved forward towards a structured program, both on-site as well as online. And now we have got the application and other things which are happening. We have e-learning program, which has got huge number of subscribers, and all of you would have accessed that. This would be something to go forward. But problem with YouTube is that you can see one video and then you forget about it. So if you want to have a systematic learning, we started off with this program of MedEClasses 4 years ago, in which we now have a fellowship program and a diploma program. A lot of programs are there. A lot of people are part of that program as well. Now, we also run regular postgraduate fellow classes, and the publications and applications are there. Applications are going to make very easy day-to-day management in that regards. The often problem which still remains is that the number of pediatric endocrinologists in the country may be around 100, and 100 may be an overrating, exaggeration. Cases are thousands. So what do we need to do? There needs to be a bridge between cases, pediatricians, and pediatricians with special interest, and then more pediatric endocrinologists. This is what we are looking at. For that, now we are trying to come up with a solution, which hopefully will come up in the next 2 to 3 months, which will help you out using a personalized, intelligent EMR. So what it will do is that based upon your particular problem, so if a child has short stature, once you say short stature, specific questions will come with regards to history, examination. This will be there for all conditions. So precocious puberty, delayed puberty, DSD, whatever, 40 conditions we are developing these protocols. You just have to enter these data. Once you enter, you will ask specific questions in examination. So for a delayed puberty, it will ask anosmia. For precocious puberty, it will ask about headache. So different questions will come. Once you answer those questions, put basic data while you are examining the patient. This is looking very benign, simple. You're just putting. But what is, and you can simultaneously assess bone age there. So it looks very simple, you're doing that. But what is happening is that behind the scene, algorithms are running, which are then telling you this is the diagnosis. This is the investigations required. This is the likely treatment. And then you will get a lot of output. And you can then export it in the form of a proper, it will give you like a proper history has been taken. You will get results, interpretation. This is a work in progress. A lot of intelligent algorithms required. It will take time, but this is the way forward. So this will allow everywhere across the country to have a state-of-the-art, quality assured sort of a management, and then there could be connections with clinics as well. So this is something which we are working in that direction. Last 3 days, we had very intense program in the Regency Center for Diabetes Endocrinology and Research. Over 30 people from across the country had come, and it was a very good interaction with over 300 cases in which a lot of interactive discussion.
So we had a 17-year-old female presenting to us with irregular menstrual cycles for the last 4 years. She also had excess hair growth over the chin, lips, chest, and back. So classical clinical hyperandrogenism features with irregular menstrual cycles. Now the history is classical. She was apparently well 4 years back when she started to have delay in her cycles, which was first in the form of delay in her expected cycle dates. Gradually started to have amenorrhea. Thereafter, classical only estrogenic bleeds, that is anovulatory bleeds of spontaneous, painless, and heavy bleeding episodes. Thereafter, around 1.5 years after she had these menstrual complaints, she started to develop gradual progressive hair growth, which started over her face, chin, chest, thighs. Now, what happens regularly is that any female with ovarian problems, that is menstrual problems, are started on a OCP by any physician seeing the girl. So similarly, without any investigation, she was started on medications and her cycles regularized. But what did not become normal is that her hyperandrogenism features that started to progress. So in spite of having relief in her menstrual cycles, as she didn't develop any clinical improvement in her hair growth, she stopped the therapy after around 1 year. Thereafter, because she didn't have any menses thereafter, she was on and off medications, and her last menstrual cycle when she presented to us was around 4 months back. She was also having weight gain for the last couple of years. Now, to exclude any known causes of illness which may cause a PCOS-like picture, we excluded regular drug intake. There was no systemic illness, no symptoms suggestive of hypothyroidism, no breast discharge, no symptoms suggestive of virilization. And there was no weakness during walking upstairs or combing hair. That is the classical history of Cushing syndrome we have excluded clinically. Now, on birth history, she was not an SGA child. Coming to the personal history, she had menarche around 11.5 years of age, after which she had regular menstrual cycles for only 1.5 years. Family history, there was no history of similar complaints in the family and no family history of diabetes. On examination, her BP was normal, BMI was high. So BMI in this case is 29.8. There was no acanthosis, FGS was 16. So FGS is suggestive of severe hyperandrogenism. Again, no signs of virilization like muscularity, receding hairline. And on genital examination also, we didn't find any clitoromegaly. On systemic examination, again, we didn't find any abnormality. And thereafter, with the clinical features of anovulation, hyperandrogenism without any obvious cause, we labeled the child as PCOS. Thereafter, we started to move in with the investigations that we normally do to exclude the known causes of PCOS. Next slide. So we ruled out the systemic causes, her liver function, kidney function, and her metabolic profile all were normal. Her thyroid function was normal, prolactin was normal. Now what came out was that 17 OHP was borderline. It was only 2.1 nanogram per ml. LHFSH was not suggestive of anything. So thereafter, we move on to the main investigations, and testosterone was over 100. Along with that, DHEAS, because the girl was having persistent hyperandrogenism, which was increasing, we also went in for a DHEAS, which was 762. Now, classically, as we have already discussed yesterday with the child, the child which came, any child having a DHEAS of more than 700 or more than 800, classically, we have to rule out one thing, and that is an adrenal tumor. And that is what we went forward with the next step. We did a CT scan of the abdomen that excluded an adrenal tumor because there was no evidence of any tumor found. Now we proceeded to the management as there was no obvious cause found. So we retained the diagnosis of PCOS, that is unexplained hyperandrogenism, and now went in with definitive therapy of EP along with spironolactone in this case. She was lost to follow-up during the early phases of the pandemic, but when she came back after around 1.5 years, she told her that she did not miss her therapy even once. So for 1.5 years, she was on EP plus spironolactone, but hirsutism still did not decrease. So this is where we started to think, was there any other cause of the same which was driving his hyperandrogenism? Investigations revealed testosterone of 140. So again, going to the virile range. So herein we started to think of what are the causes which can lead to adrenal hyperandrogenism. So I have taken this slide from Sperling. So it mentions that DHEAS more than 700, we always have to think of a virilizing tumor. Now we have excluded a virilizing tumor in this case. The second cause is of a rare type of CH, which is 3-beta HSD defect. Now, the previous line before the portion I have highlighted is that DHEAS can also be elevated in a case of FAH. So what is FAH? It is a functional adrenal hyperandrogenism. So two possibilities here, a non-classical CH, more likely a 3-beta HSD, or a functional adrenal hyperandrogenism. So how did we manage this case from here on? We stopped therapy because as these two drugs, even for 1.5 years, what was not making the person free from hyperandrogenism or hypertrichosis, we stopped this therapy for the while, started on metformin to decrease the insulin resistance for the time being, and then went in for a genetic analysis for a non-classical CH or a 3-beta HSD to be more specific in this case. Now she came back after 3 months. She was still amenorrheic. We did not give her any therapy for periods likewise, but she was still amenorrheic, and this is what the investigations next time showed us after 3 months. Testosterone of 122, DHEAS of more than 1000. Now this caused us real concern. Even if we had ruled out an adrenal tumor in the first case, we repeated a CT scan again. And meanwhile, the genetic panel for non-classical CH also came to us. There was no pathogenic mutation detected. So neither a adrenal tumor nor a 3-beta HSD defect causing this. So what is the actual defect causing this rise in DHEAS? So we made a functional diagnosis of a functional adrenal hyperandrogenism, and in this case, and so what is the management of functional adrenal hyperandrogenism? What is actually functional adrenal hyperandrogenism is that the adrenals are more sensitive. So a normal ACTH push drives up a huge production of gonads, and thereafter the DHEAS rises. There is no pathology, there is no block in enzymes. It is just that the adrenal is functioning more. Management of CAH and functional adrenal hyperandrogenism remains the same. The child was started on hydrocortisone, and after so long a duration, the child had menses after 33 days of initiating therapy. Now look at the testosterone and DHEAS level. Testosterone came down to 73, DHEAS to 462. So a working diagnosis at this point of time remains a functional adrenal hyperandrogenism. But there is a question which most of you will ask. If the management is same, can we differentiate these two biochemically? Because most of the books still say that after the ACTH stimulation test, if we do a 17 pregnenolone by androstenedione ratio, then we can make a diagnosis of 3-beta HSD. Now, this is what I show again from Sperling, is that after the ACTH stimulation test, if the ACTH rises to more than 10 standard deviation, then it is non-classical CH. But again, Sperling in the same page mentions that even a rise of more than 10 standard deviation is only suggestive, not confirmatory. The next line, the primary functional adrenal hyperandrogenism also shows a rise of 17 OHP. So a biochemical diagnosis of 3-beta HSD versus functional adrenal hyperandrogenism cannot be made. Second, this is the paper which came out in the Journal of Clinical Endocrinology in the year 2004. This is what they did. All the patients who had a biochemical diagnosis of 3-beta HSD2 deficiency, they collected all the cases and went in for a genotype. Now, what did they find? They found that even who had no defects in 3-beta HSD, they had a ACTH stimulated 17 OHP of more than 12 standard deviation. So again, this is the point I want to highlight, that you cannot confirm a diagnosis of 3-beta HSD versus functional adrenal hyperandrogenism on a biochemical picture. You have to go forward for genetics, and as we freely have genetics available, so this might be the way forward. Now, one more thing, why we should do genetics in this case? Because although the management is same in the two cases, you have to give hydrocortisone, but one, CH will require lifelong therapy. This may not require lifelong therapy. If the patient has decrease in his weight and this child has a persistent stress, because his mother passed away a couple of days back and she has been transferred to a place where she is having language problems. So maybe stress is driving this excess adrenal production. We believe this will come down, but as soon as we try to decrease his hydrocortisone dose, the child again goes into amenorrhea and we again have to increase this. How long will we go forward? I have no idea, but we hope this is not a permanent problem and we can taper the dose and clear it. Thank you.
First question is that clinically,
yes, sir.
Were you suspecting non-classic CAH?
So not clinically. When the reports came, we had to.
Okay. Now, what genetic test did you send?
So we sent a panel for non-classical CH.
I see. Which lab does
So
that?
MedGen.
Okay, because I'll tell you similar presentation. The 17 OHP wasn't raised out.
So
Yeah.
2.1.
So we were
Huh.
actually not thinking of 21 hydroxyl deficiency, we were thinking of 3 beta HSP.
But we can't do treatment alone out here.
Yes, so that's what we are trying. Finally concluded that even if we do biochemical, that is not going to be a final answer, because a lot of these patients with FAH will actually have a much higher level of 17-hydroxypregnal alone as compared to 3 beta HSD individuals. So you can't say the biochemical test is not going to tell you.
What was the ratio between the
So we did not.
DHEAS and androstenedione?
We
That would have thrown some light.
Yeah. So we have looked at DHEAS pretty much at that point. So DHEAS was more than 1,000, which was very much warning. We got CT twice. And once that has been done, we decided, okay, if I want to look for 3 beta HSD, I'll go for genetics rather than any more biochemical parameters.
So the point I'm bringing is, nowadays, because this is how I stumbled on it, I just want to share this with you, that as you know, for 21 hydroxylase, MLPA standard is good enough. So they look for duplication, and it is a cheap test compared to the clinical exome, the whole, whole exome sequencing, CES. So what happened is, there was this child who, for a long time, was being considered as a CAH, but this was negative. What was it? The MLPA was negative. Still, I kept treating. Because this patient had come with severe salt wasting crisis, and it was a girl. There was some, there was some realization. So then when I said, well, now the child is 2.5 years old, I started weaning off the alcohol and this protocol. And then the father, who was really sharp, I said, anything happens, let me know. In 36 hours, that baby decompensated. That was not a baby, it was a child. I mean, it was a toddler. Decompensated. We started the medication. And I said, look, so I sent a clinical exome sequence, and it came back as 3 beta HSD. So what I'm trying to say is that if you do a clinical exome sequencing, because nowadays we have a geneticist on board in Calcutta, and I've been in Apollo, so I've been talking a lot. So clinical exome sequencing, because now ultimately what has happened is you have a patient or a child or an adolescent with functional, where even a little bit of ACTH is making him run, is like basically a cocaine snort, I mean, start moving. Versus traditional or non-traditional CH, where the treatment is the same. So my question now, because I noted that you gave 10 milligrams per meter square, which is actually suboptimal for a CH, and that is working. So maybe that is what
this is FAH. Yeah.
But the paper you showed were 3 beta HSD, coming with PCOS, but then you should have been able to prove the 3 beta HSD.
Yeah. So that's what
That was
that's
a biochemical diagnosis of 3 beta HSD via the standard ratios of 17-hydroxypregnalone, androstenedione, urine steroids. They did multiple studies, and then they went in for a genetic diagnosis of that entire cohort.
That's what. But in your case, the genetics is negative.
So this is not this is not 3 beta HSD. We are saying this is FAH.
Exactly.
This is FAH. This is not 3 beta HSD. This is our final diagnosis.
That's right.
And the message, the other big message is that all this testo DHT ratio for 5 alpha reductase, this 3 beta HSD androstenedione ratio, these are just suggestive. They are not the final indicator. You have to go for genetics these
But
days.
even then, this diagnosis by exclusion.
Yes, so we have excluded everything.
That's right. It's a diagnosis exclusion.
Yeah.
And the second thing out here is that the fact that low doses are helping.
Yeah.
But is there no, what was the trigger? I mean, why was this DHEAS galloping like that?
So FAH, some people are hypersensitive to the same level of ACTH. That's what FAH is.
No, but it was progressive. Why was it progressive?
No, initially also it was more than 700, 800. It came down in between on some other medications, I think, and then on steroids they came down. So we are only able to control it when we are giving a physiological, sub-physiological sort of a dose of steroids. So it looks FAH clearly in that case. So the message is that if you have significant hyperandrogenism, do testo. Testo, if it is more than 100, 150, go for imaging, number one. Number two, look for DHEAS. If DHEAS is very high, look for adrenal cause. If you have ruled out adrenal cause, think of FAH versus 3-beta HSD. So this was a confusing case, but final our diagnosis is
But
FAH.
I just want one thing, that is science, your job tomorrow or whenever, is to call MedGeno and see whatever test you have done, the panels. Because panels sometimes.
No, this is exome sequencing, whole exome, clinical exome. Clinical exome. We did not ask for 3-beta, it was clinical exome sequence.
All right. In the clinical.
Yes, yes.
Then if they have not found it, they are
Yeah,
not.
it is clinical exome sequence. Okay.
Sir, I'd like to differ a little.
Yeah.
Sir, what is the harm in doing a post-intraoperative test and after that a urinary profile or something? So that
Because see, ultimately what has finally come out, like this paper is what is telling us that whatever ratios you use, patients who have a genetic defect and those who do not have are the same level.
Yeah.
So it is not going to be of any consequence in terms of making the diagnosis. See, ultimately, haath kangan ko RC kya, like you have to go basically for the final diagnosis. Genetic, yes, no, because then again you will spend much more money. 17-hydroxypregnanolone will cost thousands of rupees. So same money, they'll send to US, Quest will take 10,000, 20,000 rupees. By the time you get the genetic diagnosis, it's done. So it's changing. I think we have to adapt to that also, that things are changing now. Dada's case, SLO, the lipoid hyperplasia was diagnosed just based on genetics, because they hadn't done that much profile, steroid profile, and genetics got it. So we have to be ready for that. There are caveats in genetics, which I'll discuss in detail today, but we have to assume that genetics will play a more important role in making diagnosis.